Steve Freeborn, I've been a pharmacist for about 100 years.
Surely more.
Thank you, Ian. It's nice to see some friendly faces amongst the audience and some not so friendly faces, but anyway. My history is around being a pharmacist in the NHS as a chief pharmacist for a non-teaching hospital and then for a large teaching hospital. I've also done work for the PCT. Oh, I don't think they've got much of a future, but there you go. And I've also done some locums for Asda. So I've got quite a range of things. And one thing I did leave out was to say that I did work for an IT healthcare company for a number of years, where I tried as best I could to promulgate e-prescribing as the thing to be in, the thing for the future. And there are many, many reasons why I tried to make that happen. Sometimes successfully, sometimes not. And I'd just like to, if it's okay with you, I'll just share some of those things with you. Okay, let's just say, this is a hospital ward, as it was. Perhaps in some of your places it still is. But now you can have ensuite rooms if you're very, very lucky. The theatre, as it was, I particularly liked the bucket, which was there to catch any bits that fell out during the operation. Things have moved on, loads of high-tech stuff, and that's the way we see theatres now. Bit of a problem, really. Not a very pleasant experience having an operation. This isn't 1931, by the way. It's 1940. No! It's a lot earlier than that. And of course, we now move on to this. So things are moving. Things have changed. Mustn't forget that. However, notes, patient notes. This just carries on. Look at that. The only thing that's changed now is we're in colour. Because it was all black and white then. Things have to move on. I'm sure we all agree. Why is it not happening quicker? Okay, in the beginning, pharmacist viewpoint on all of this. In the beginning, where did it start? Pharmacy was a great mysterious alchemy. A place where there was a hole in the wall in the pharmacy, in the hospital, and you shoved stuff in, notes, requesting stuff, and it came out or didn't. It was basically a manufacturing science. And you knew you were in a pharmacy that was really doing well if you looked up and you saw little yellow stalactites on the ceiling. Because that was a pharmacy that was making their glycerin suppositories well. If you threw your glycerin suppository on the ceiling and it stuck, you'd made a really good batch. So that's where pharmacy was in the 70s when I started in all this stuff. Handwritten prescriptions and labels. Can you imagine that now? Handwritten labels. Unbelievable. Then we got printed labels, which was a step forward. Prescriptions, however, Computerization really took off in the 80s, mainly because pharmacy had started to move away from the manufacturing side of things. Other people were doing that now. There were companies coming in and making stuff far safer than you could ever make it in a hospital. I always remember making IV fluids in a room just outside the chief pharmacist's office. And people would be walking past, joiners and all sorts of people. And you'd be there stirring the normal saline before you put it into glass bottles for sterilising. What? Yep, I'm afraid it was. So, computerisation took off, really so that we could store drugs properly and buy them in the best possible way. Computer-generated labels started. A little system called the Richardson system appeared, which was a massive breakthrough because you could actually code nitrazepam, 1N, and you got 1 at night on a label. Absolutely astonishing. I'm silly really, because I have these sort of bright light moments where things go, wow! I get so excited. And the people look at me and, what? It does that? What else does it do? But I think that's fantastic that you could actually get that to happen. TV still amazes me. So at this point, pharmacy was moving on and the procurement side of things was getting pretty boring. So the one or two pharmacists, especially coming in from America, that decided that they were having great success actually going on ward rounds with consultants. Talking to consultants. Astonishing. And things started to happen in this country. I was lucky enough to go to Hope Hospital in Salford and do an MSc in clinical pharmacy. And I was ward rounding with a guy called Prof. Turnberg, who was such a wonderful man. And I'd be on the ward round and he'd say, now we're trying antibiotic X, Y, and Z, Mr. Freeborn. What would you recommend? Oh, what? But at least I had enough information to usually blag my way through it. But you could see that was the way that pharmacy had to be. Head full of drug knowledge. Head full. Young doctors there, 6 weeks. Pharmacology. Who's got the better knowledge? Had to go down that route. So at this point, prescriptions started to become critically evaluated. People started to ask questions. And oh boy, did we find things. Lots and lots of errors. And they became obvious. There were many attempts to improve prescriptions across the country. I'm talking about hospital prescriptions now. And you could go into different hospitals and you'd have different systems of handwritten prescriptions. And there were many, many attempts to standardize. Didn't happen. Did not happen. I tried in the Northwest. I started up a team of chief pharmacists and we all brought in our prescriptions and there were a million reasons why you couldn't change each one in each hospital. And I suddenly had one of those bright light moments then and realized that in fact these prescriptions don't belong to pharmacy. I thought they did. They don't. They belong to pharmacy and nursing staff and the hospital and the doctors. Wow, pharmacy isn't the centre of the universe. What a shock. So, what happened was, from then on, there was a general move into IT in hospitals, and I'll tell you why. Mrs. Thatcher stood up in the House of Commons, and she said, this NHS that we have, how much does it cost? So somebody gave her some huge number. How much of that is spent on nurses, doctors, pharmacists, all the professions? What do we get for our money? What? What does a hip operation cost? No answers. It was just this general lump of money. Not good enough. What we need to do, well, she didn't say that, but her IT people says, we can help you there. We need to introduce a case mix system. This will identify a disease and the cost to treat it. So that's nursing costs, any cost involved in that disease. So they threw a massive amount of money on 6 centres in the country to kick this off. And then this worked for about 2 years. And then if you wanted to join in any other hospital, you made your case and you got £2 million. Now think about that. That was a lot of money then. £2 million to bring in your own case mix system. So IT was in. And on the back of that, some hospitals began the concept of electronic prescribing. Tremendous. 2 of the hospitals that I know of, and you might know more, but 2 of those major hospitals that kicked off, the Wirral and Burton, are still very active in electronic prescribing. And they've spent a lot of money on it, but it works. They do see results from doing what they do. The unfortunate thing about all this was, in 1994, the money stopped. Very difficult to carry on with major systems if you've got them in place if you don't have the funding to do it. So it became very, very difficult. In the GP land, we started to see electronically typed prescriptions coming through. Absolutely wonderful. Paid for. Because the PPA, the Prescription Pricing Authority, who actually pay for or refund the money for the prescriptions, couldn't read prescriptions. So they were complaining. So it was a financial issue. And that's just taken over and carries on, no problem. What's the driver in hospitals? Think, what is the driver in hospitals? For me, it's patient care. Hang on, isn't that what we're supposed to be doing? I don't know, money speaks louder sometimes, which I do find annoying. At this point now, we're moving on and we started to get into what I call, and you've probably heard the word before, pilotitis. And everywhere you went, somebody was trying to do a small project. Every hospital you went into, and you'd get the odd developer or two developers sat in a room, bashing out a beautiful piece of software that would work for a small area. You should sit all over the place. Then the developers left, one of them left, and it all started to collapse. This is all over the place. Little bits of pieces of work, some of which were absolutely splendid. The thing that I would say at this point is, if we are going to get involved in these things, think wider than a specific small project. Always think, if this is successful, what happens? What do we do? Where do we go? That's a very, very important issue. Where do we go from here? The thing I learnt as well was it's not simply a pharmacy system. Wow, that was a bit of an eye-opener for me again. And you need a definition that says, what is this electronic prescribing that I'm trying to do? The main thing about it for me is to pull together all the possible information you need to produce a safe prescription. That's what it's all about. Pull the information together for the prescriber. Are we talking about email prescribing here? Anyone can do this. Anyone. I don't know if you can see it. I've got tabs digoxin here, 125 micrograms, take one a day. Dr. Freeborn, SHO. Oh, and I'll send a copy to the nurse, so she knows as well what's going on. Some people would say, yeah, it's all right. What? Not so good. I don't think we're moving on very far, are we? Although you could have a spell check that got your drugs right, couldn't you? Okay, so electronic prescribing, what are we trying to do? Some things I've learned really is, when you're sat there and there's a patient with you and you're sat with a doc, the things that are going through their head before they actually prescribe a drug is something you've got to try and help with and replicate as much as you possibly can with your system. Okay? The first thing I learned as well in my pharmacology stuff was, is the drug needed? What am I giving this for? Why? If there's a non-drug solution, let's use it. They're all poisons. So let's get it right. Why am I doing it? Okay, so I've chosen a drug. I've then got to think about other diseases. Is there some renal failure going on here? Some liver problems going on? Can this drug be affected by that particular problem? Concomitant medication. What else is being given at the same time? Drug-drug interactions. I'm going to share a story with you now. The lesson of Tommy Tazica. I was on a ward in a hospital. It was in the Bolton Hospitals, Ward D3, elderly. Went on to see this chap. His name was Tommy Tazica. He's dead now, so we've got no problems. I mean, just telling you the tale. I mean, So anyway, I go in there and I'm looking at what medicines the guy came in with, and he's on 23 different medications. 23. Talked to the consultant about it, a great guy called Arup Banerjee, who's into elderly medicine, and very, very bright man, and we were always trying to reduce the meds that these people are on, possibly because of interactions. Other things might be going on. And you started with this chap. I walked in and said, hello Mr. Tazika, how are you? Bloody awful. All right. Are you taking all of these medications? Yes, I am, but I've no time for anything else. Okay. So we started off. He says, went to the doctor with a pain in me hip. And I got these. He's got ibuprofen. Oh dear. He said, but then I got sort of stomach pains. So I got these. So he takes some ranitidine. Unfortunately, he's one of the 0.5% of people that when you take them together, he gets edema. He gets lots of fluid retention. So he then gets frusemide. It says on it 1 daily. So when does he take it? At night time. I'm up and down to the toilet every 10 minutes. So he now gets nitrazepam. Unbelievable. At some stage, he's taking GTN as well for the pain that I think is still from the ibuprofen. So he takes the GTN, he gets terrific headaches. So he then starts to get codeine phosphate, which is popping in every 10 minutes. So he ends up with constipation, which he gets Senecot and Fibergel, Ispigula, for. So he's taking all of the, here's a tip as well, never make Fibergel up in a glass and leave it. Ever. You never get it out. One thing you can do is mix it with milk and it becomes like a sort of mousse. It's quite nice. Drug-drug interactions. Huge issue. Okay? That guy actually he left the hospital on 6 drugs from 23. And he went back to being a window cleaner at the age of 82. Well, that was quite a nice story. Pregnancy as well. This is a massive issue. Who asks the question before a drug is given? The person, they might be pregnant, they take the medicine, and then they worry for 9 months about this medication that they've taken. Just think about it. It's a major issue. Age, once or twice a day. Oh, dear. The elderly patients that we have, a lot of them are superb. And we're all told now we're going to live till we're 120. Well, I won't, but a lot of you guys will. So this is an issue. We try and give patient drugs 4 times a day, the elderly. They can't handle it. They get it all wrong. I'll give you an example now. I went round to see a patient. In his house. We were doing a project at the hospital I was working at. So we visit elderly patients up to 6 weeks after they left the hospital, just to see if they were handling the drugs properly. Walked into one chap's house, and on the wall was that. Like that. And at first of all, I thought, what is that? Is that an optic for a gin? And underneath it on the wall, he had, because it was a white wall, he'd written, big spot, 1 times 3, 1 times 4, all the way along the wall. And he said, I can't remember what to do with these things. He says, so it's dead easy. I just go along and I just press it up and I take off and I well once and then I screw it back again. Do you know what? I was talking once to a women's institute and a woman shouted from the back, what a great idea. Don't underestimate the problem we've got. We're trying to get people to understand the medicines that we're giving to them. Concordance. When you talk to somebody as a pharmacist, what do they understand about what you're saying? Well-trained pharmacists get them to reflect back to you what you've just said. All right? Males handle drugs differently to females in some cases. Some cases there are complex calculations that need to be done. There are ethnic issues, glucose 6-phosphate dehydrogenase deficiency with quinolones, like ciprofloxacin, can cause hemolysis. Do we know that? Have we looked at the lab tests recently to find that out? Side effects from the drugs that we're about to give, are they accounted for? This is all going on in this guy's head while he's prescribing, or is it? Allergies, do I take account of allergies? So how do I actually prescribe? Evidence-based approach, how do I prescribe? Well, usually it's background knowledge and university training. Training is absolutely essential. Very, very good training. Often they'll ask other doctors, pharmacists and nurses, and often on wards you'll find the nurse is driving the prescribing. So you mustn't ever forget that. If you're getting involved in any of these projects, remember how key the nursing staff are to all of this. Reference sources are used. The BNF by standard is often used, plus any other gadgets like Google, which doctors often use, and pharmacists. And finding information from results reporting. I need to know from my results reporting software what's actually happening before I prescribe. So I'm looking at, say, a multi-departmental view, and I'm saying, give me some information. I need that now. I need that when I'm prescribing. Or I need some clever piece of software that changes things for me and tells me why it's done it. So, you make a decision about the prescription, you start to prescribe. What do you usually get in a hospital prescription? Well, you often get the medication written. Often get a dose. The form's a bit tricky. The oral, you say, but what? Capsule, tablet, liquid, nasal bougie. What? And often you see, medics don't know what these things look like. They really don't know. So never assume anything about that. And you'll need a frequency. So very simple. That's basically it. Do we have any help to say that when we go into e-prescribing, there's some direction that says, yes, you must have this. If you're about to go to an electronic prescribing project, you must follow these basic rules. Well, yeah, go into BNF now, edition 62, and you'll find a page on e-prescribing rules. Very simple, very, very simple. Because this is guided towards the GP. And it even says on there, which shocked me a little bit because I've not read it for a while, may contain usual dosages, can be programmed to recognize generic names. Well, it's a bit wishy-washy. And I know that NPFIT produced a load of stuff around how you should be doing this thing properly. And we know what needs to be done, but it's actually getting there. This makes me cry. This makes me weep. How did we let it happen? It's absolutely appalling. Handwritten prescriptions on wards. The eagle-eyed pharmacists and perhaps the docs amongst us would understand what a lot of that stuff says. I introduced a prescription that said write in block capitals. It lasted for 48 hours before I was swamped in pharmacy by nursing staff complaining that they couldn't give medicines because they weren't in block letters. And I tried, and it kept falling to bits all the time. And eventually you give up. I did. And you end up with this nonsense. This is one of the worst cases. There are many. I know Gary's got a load of these things. But if you'll just, I'll just point this one out to you here. This here actually says 4 units of insulin. 4 units. What does it get written to on the next line? 46 units of insulin. Bit of a difference there. Not a very well patient. Honestly, it makes me weak. I just don't know how we're still doing this stuff. It's just ridiculous. And you go back over the papers over the last 10 years, and there are masses of papers around all of the problems that this type of prescribing causes. Simple stuff I did with the Audit Commission in 2001. We produced a paper. Lots of chief pharmacists were involved around the country called Spoonful of Sugar, which produced some guidance around computer prescribing. But as the research was going on for that piece of work with the Audit Commission, it became so obvious that people were dying because of poor handwritten prescriptions. Some of the figures there, they just carry on and on and on. It makes you think, why don't we do something? Well, we are trying, I know, so I don't want to be too negative. I know people have been quite successful. This was a paper that was in the Independent, and there was a line at the bottom that really struck me. By using a correctly programmed computer, we believe we can reduce prescribing errors by 90%. This came out of some work that there was a presentation in Bournemouth. I think this was around about 2006, 2007, where they were saying there's too little progress. Like we're saying, or I'm saying, now. And this was 5 years ago. What benefits then from ePMA? What benefits have we got? No handwriting. Simple. No transcription. Choice of medication can become rational. It reflects on concurrent treatment, what else is being given. Clear continuity and timely transport of information. The thing is, once you do this stuff and you get it computerized, you can send it. So you can link up secondary and primary care so easily. It's much easier than sending stuff through the post or saying to the relative, take that to the doctor when you go. Displayed on the ward round, the information about a patient. I went, I'm a lucky man, in 1999 to the Latter-day Saints Hospital in Utah, Salt Lake City in Utah. Went on to a ward. I had to join in with the Americans doing a ward round. Do you know what time the ward round started? 7 o'clock in the morning. Frightening work ethic. Anyway, I went there, and they were all sat there in this room, drinking huge coffees about this big, and cakes. Lots of cakes. I sat there with them, and I thought, what's going on? And I'm sat there with a clinical pharmacist, radiologist, consultant, lots of young housemen around. And he said, right, we're going to start off, we're going to do and have a look at the patients on my ward. I thought, what? They're not here. And just click. And on the screen, all the information about the patients appeared. And he said, I want to see the meds. Let me see the meds. On the screen. Okay, let's see the bloods. I turn around to the pharmacist and say, what do you think? What should we do? And I just looked at this. And I go back to my ward round with my elderly clinician. Sorry, clinician on the elderly ward. Rehab. And he pulls out a drug file like this, a flipping patient's notes. And we stand there for 20 minutes looking for the latest blood. And I'm talking now about 12 years ago. It's not good, is it? It's not good. So displayed on a ward round, really good stuff. Forms part of a life record. Once electronically stored, it can be easier to retrieve. That's all right as long as someone doesn't decide to knock out every power station in the country. That's something else to think about. What do we do? What do we do? Anyway. Transportable, I said that earlier on, especially if you've got web access. This is how we've got to be thinking. How we've got to be thinking. I want an Android app. And I want hospital, ward, patient, drug, dose, go. Thank you. Next one. And you guys are going to make that happen. Electronic prescribing in hospitals has proven to be extremely challenging. I think to remember, it's not a single disciplinary system. When a GP writes a prescription, it goes to the pharmacy, and the patient receives a medication. That's it. Off you go. You either take it or you don't. Not the same in hospital, is it? It's hugely different. Because you have this person called the nurse who needs good information about this medicine. How do I give it? How do I give it? When do I give it? What formulation should it be? Oh dear. This then gets a little bit more complex because we have a third person involved in the transaction. It can even get worse because the concept of self-medication comes in. And in a lot of hospitals, this was happening as I was leaving the hospital service. I don't know if it's still being pursued, but instead of having hospital trolleys being pushed around, you had a cabinet at the side of the patient's bed with a key on it. And your medication was put in there. And if you wanted to self-med, you could do that. Because people are coming in with an ingrowing toenail, and they're going to be staying in for 3 days, and you take 20 drugs off them, and then resupply. Does it make any sense? So they wanted to self-med. Now you'll tell me later on whether that still happens or not. But that was beginning to happen. So if you're starting to do that, how do you let the nurses know that the patient's self-medding? Do they let you know? You know, it gets more and more complex. So you have to think these issues through. And you have to process plan the whole thing for every individual ward, because they might, well they will, be very different. If you're going to start one of these things off as well, don't forget that you have to review and update continuously. Anything you introduce, do you have a team of people doing it? How are you going to do it? Is it within house? Do you bring somebody else in to do it? In the past, development costs have been huge and very, very lengthy. I'm expecting that to change as people have begun to realise there isn't as much money in the NHS now. So if you're going to start projects off, you're going to have to do them quickly to get your money in. And I would imagine now that we're going to see IT directors pulling their budgets together to say, well, you don't have to follow a national programme now. I want to go down this route. I want to spend this effectively in this way. So they need to know what the priorities are. The one thing I must say at the end of all this really is it's got to be a multidisciplinary approach that you have. It has to be. Please don't think that the pharmacy can do it on their own. Please. You know, I've learned over 100 years. Don't. I once went to we have this thing called UK CPA. Ian knows about it. Ian Bourne's chief pharmacist from Eastbourne here. UK CPA, Clinical Pharmacists Association. In the early days, we were talking about electronic prescribing, and there was one chap there from a hospital I won't mention. She's like, no, I won't. and he brought a laptop in, you know, and he said, it's dead easy, this. You can do an e-prescribing stuff, and it'll cost you about £3,000, and you just produce a label and stick it on the prescription. And there were so many issues around that you couldn't really see it ever working on a large scale. But we were led to believe that that's the way it was all going to be. And it was a pharmacy project. I don't know. So, the route to success. Oh, these are my views, remember. There is no established route to success, but it's just my views. If you think you want to attempt some of this, your top management at your hospital have to agree to it. They have to know what you're attempting to do and why you're going to do it. And make sure that your case is really strong, because there are a million other things that are going to compete for that. A million. So be strong, have a good leader, and get them in there with a passion. They have to have a passion for this, or it won't happen. Your chief exec has to commit a resource to set up a team of clinical and IT people. And don't believe this is a whole IT project by any stretch of the imagination. That's a small piece. Especially now technology is moving on so quickly. That's a small piece. The difficult things are the hearts and minds and the training. Oh. Having said that, somebody says, oh, no, I'll be dead easy because I just got my phone and I just did this. Yeah, that's okay for you, but there are lots and lots of people who don't have your confidence. Okay, so think wider. Defined milestones. Where are we going and where do we want to be? And who's going to monitor it? Do I have a project manager that's going to see this through? Because they're the only people in my experience that will do this. Somebody that has the responsibility to make it happen. And not all bits and bats of people who they'll go off on their own way and succeed and fail. Oh, it has to be a coordinated response. The resource committed must realise that once your ePMA is set up, it ain't going away. It has to keep going. It has to keep going. I've been involved in projects over the years where you've started these things off, they've been pretty successful, and then they stop. Well, the second time you try and introduce that, it's almost impossible. I'm a bit doom and gloom here, aren't I? I'm sorry. But you're going to cheer me all up later on, aren't you? And you're going to tell me how well you're doing. So this is fantastic. But you can't fail, all right? Final thoughts from me. There's a lot of concern, and I'm speaking now from my own profession, please. Just give me that for 2 minutes. There's much concern over cost containing in the NHS at the moment. And I've noticed, and I've spoken to colleagues recently, whereby there is a drive to push pharmacy back from the wards into the pharmacy, mainly because of cutting staff and all of this stuff, to go into the procurement side of things again. Driven by, if you can buy things cheaper, we can save money. In my million years of experience, that's wrong. That is absolutely wrong. You involve your clinical areas, you involve your clinical knowledge, and you control your prescribing. Controlled by formularies within house that everybody agrees to. You get optimum prescribing and you'll get optimum cost saving. There's loads of evidence for it. So don't fall into that trap. It's too easy. And I'll tell you, there's nothing more boring than a piece of paper coming in through a hole in the wall and you fill a box with drugs and you send them out and then you get the crossword out for the rest of the day. Because I've been there. Awful. What a waste of talent. If you see that happening, tell me, and I'll see your chief exec. ePMA can go a long way to making this happen, optimum prescribing, but pharmacy has to be involved in a big, big way. I love this statement. I've seen it. I've used it 1,000 times, the first one. He wrote in a doctor's hand, which from the beginning of time has been so disastrous to the pharmacist and so profitable to the undertaker. And my favourite Winston Churchill quote, those who fail to learn from history are doomed to repeat it. Please, my profession, don't do it. Don't go back. Thank you for being so patient, everybody, and letting me rant on. I've enjoyed it. I hope you have. Thank you.